Okay, everybody, I think we'll make a start. Just conscious of time and we've a lot to get through. Good afternoon, everybody, and welcome to the second session this week of our online bite-sized lunchtime learning sessions as part of the Greater Manchester Falls Prevention Awareness Week. Just to give you a reminder, we are recording today's session and the link will be shared on the GMCA YouTube channel along with the slides for you to watch back if that's okay with everybody. I'm just going to briefly take us through the agenda. So as you'll see, we've got 3 different speakers today. Our first presentation is going to be on digital technologies to prevent falls in people living with dementia. And we've got Charlotte from the University of Manchester who will take us through that shortly. Secondly, we've got Elaine from Your Trust at Rochdale, who's going to talk about the falls prevention collaboration work happening over in Rochdale. And then finally, we've got a presentation on the effectiveness of dance interventions of falls prevention in older adults by Kimberly, again from the university. So yeah, really detailed session. So I am going to make a start. The format we'll have sort of an 8 to 10 minute presentation from each speaker, and following each presentation, we'll have a short Q&A for any burning questions. If we do have a number of questions and we can't get through those, I will take those away if you just pop them in the chat and contact the speakers and get back to you directly if that's okay. So I will hand over to our first speaker. So Charlotte, if that's okay, I will move the slides through. So if you just let me know when to move on, that'd be great. Thank you.
Great, thanks, Beth. So as Beth said, I'm going to talk today about a piece of work we completed around the use of technology to prevent falls and falls risk for people living with mild cognitive impairment or dementia. So I'm Charlotte Eost-Telling and I work in the ARC Healthy Ageing team at the University of Manchester. And I worked with my colleagues in the NIHR Older People and Frailty Policy Research Unit and the NIHR ARC GM to conduct this, which was a rapid review of reviews. So this work was undertaken alongside a wider review looking at the use of digital technology to support people living with dementia and their carers. But in the review I'm talking about today, I'm going to talk about how we specifically focused on the use of technology to prevent falls in people living with dementia, because we felt that was a really important area that warranted a separate focused review. So next slide, please, Beth. Thanks. So first of all, we know that the cost of falls is a huge burden on health and care services. 30% of people over 65 will have a fall each year, and that rises to about 50% in the over 80s. But if you add into that the complexity of dementia or mild cognitive impairment, then these people are more than twice as likely to fall and nearly 4 times as likely to have recurrent falls as people who are cognitively intact. And on top of that, when they do fall, they have a higher risk of sustaining a fall-related injury, and their outcomes after injurious falls are worse than those who are cognitively intact, sometimes because they're less likely to be offered or to access rehabilitation when they do fall. Next slide, please. So there are a wide range of complex and interacting reasons to why people living with dementia might have a higher fall risk. These can be not just physical, but cognitive and behavioural as well. So, for example, if you have poor mobility and muscle weakness, which we already know increases in older age, but is even more likely in people with cognitive impairment. So if you imagine you're walking and you aren't actually quite sure or confident when your feet are actually going to land, and that can cause you to stumble or trip. Or you could be taking medication which causes dizziness, so you go to stand up and you become dizzy and disorientated. In addition, cognitively, people living with dementia and mild cognitive impairment may have trouble interpreting their environment through deficits in visuospatial processing. So, for example, they might go to sit in a chair but aren't able to see it properly or to work out exactly where to sit, so they might miss the seat. And then difficulties with memory can make everything seem unfamiliar, and it becomes more difficult to find your way around and avoid trip hazards. And depression can also impact on reactions to changes in the environment. Behaviourally, we know that people with cognitive impairment are more prone to risky behaviour and impaired judgment. So if they, for example, may not even see any danger in standing on a chair to change a light bulb or hurrying downstairs to catch a phone call. Next slide, please. And this is really important because we know that the number of people living with dementia currently stands at about 900,000 in the UK, but it's predicted to rise to 1.6 million by 2040. And obviously that in itself is going to be a huge increasing burden on health and care services. So technology is rapidly evolving, pushed on by the impact of the COVID-19 pandemic, but we actually know very little about which technologies are the most effective and cost effective for people living with dementia and mild cognitive impairment. There is some evidence for people who are cognitively intact, but there's a big gap in the evidence for those with cognitive impairments. So we wanted to know what the evidence was available to show that technologies can reduce falls and fall risk for people living with dementia and mild cognitive impairment, and to identify the gaps in the evidence base. So that'll help us to direct future research and generate new insights for policy decisions. Next slide, please. So as I said, this was a rapid piece of work, and we drew on previous work carried out in our group around technology and falls in later life. We followed a systematic review of reviews approach and searched 6 databases, using searches around exergaming, digital approaches to strength and balance training, and the use of mHealth and eHealth, all combined with search terms around falls and dementia and mild cognitive impairment. We included people of any age living with dementia or mild cognitive impairment, and we focused on community and supported living or residential care settings, but we did exclude hospital settings. We also included any digital technology aimed at or exploring reducing falls, and the outcomes we included were falls, fear of falling, and fall risk, which also included measures of balance and posture. Since this was a review of review, we only included systematic reviews. So our initial searches identified 187 potential studies for inclusion, and after screening on full text, we ended up with only 7 systematic reviews which met our inclusion criteria. We determined the quality of the reviews using the AmStar 2 tool. So the main types of technology we expected to find evidence around were wearable technology or sensors, environmental sensors or sensor-based systems, exergaming, virtual reality system, and apps. But we're also open to finding any other types of technology that were out there as well. Next slide, please. So we classified the evidence we found according to the key technologies that emerged from the literature and organised them using the far-seeing taxonomy, which can be used to classify and describe technology use in falls prevention studies. All the technologies we identified were classified as systems, which meant they're a set of interacting components, although they differed in terms of locations, being either body-worn, environmental or portable. They also had a range of uses, including prediction, detection, monitoring and prevention. So we synthesised the data from each type of technology we found, and I'll talk through that on the next slides. So next slide, please. So we look first at wearable technology and sensors. We found 2 systematic reviews with at least some evidence on the use of body-worn sensors with people living with dementia. Excuse me. Both reviews focused on dementia care homes, and they included 7 primary studies with a total of 845 participants. Measures of balance and stability were taken using sensors which were placed at the lower back, trunk, waist or chest. And the data from these sensors was analysed against records of falls. So both the reviews concluded that wearable sensors were an acceptable tool to distinguish between fallers and non-fallers, and may be used to predict falls in people living with dementia. But the reviews also indicated that more work was needed to explore sensor location and the attachment type and the assessment used to ensure that the accuracy and acceptability of the findings was high enough. So we assessed both these reviews as critically low on AmStar, in part because they didn't consider the sources of bias in the primary studies that their conclusions were based on. Next slide, please. So if we turn to look at environmental sensors, again, we found 2 systematic reviews reporting falls measures in studies using environmental sensor systems with people living with dementia. These focused on community dwelling participants or those in long-term care homes, and reported evidence around the use of digital care technologies, including bed sensors, night lights, tele-assistance services, and electronic support bracelets, either on their own as part of a package. So the reviews included 6 primary studies with 427 participants, and both reviews included falls outcomes, but both reported inconclusive evidence. So the first review reported that 2 studies found no evidence of an effect of using sensors on falls, and the other study showed a significant reduction in falls was actually biased by staff attitude to the intervention and showed a reduction in falls only after the intervention was actually removed. The second review was included 3 RCTs, and a meta-analysis of 2 of those revealed that the probability of a participant falling was 50% lower for the groups with the assistive technology, and the overall effect of the intervention was significant. But again, there was an unclear risk of bias, and the interventions they combined were very different from each other. So differences in the findings may be due to the fact that there was very small study sizes, and so there were differences in study design, the interventions, and the outcome measures. So we rated these as low or critically low on AMSTAR. Next slide, please. So if we looked at exergaming and commercial games consoles, again, we found 2 systematic reviews on the impact of exergaming for older people living in community or assisted living facilities. The studies used WeFit or Fit for All platforms and measured strength and balance outcomes rather than falls per se. So these 2 reviews had a high overlap, but we did find 101 unique participants from 4 primary studies. Subgroup analysis for the cognitive impairment or Alzheimer's participants of 3 of those studies indicated an improvement on balance outcome measures such as the Berg Balance Scale. But the findings have to be interpreted with caution because the subgroup was actually really small and there was low confidence in the results. So again, we rated the reviews as being low or critically low, parts because of the small numbers and the lack of looking at bias in the original studies. So next slide, please, sorry. So if we look at virtual reality, we only found 1 systematic review looking at the evidence around the use of virtual reality to improve health outcomes for community dwelling adults. And that actually only included 1 study with 39 participants, which compared people living with Alzheimer's who had a history of falls. They compared them with people with Alzheimer's without a history of falls and people who were cognitively intact. And the study actually used a virtual reality headset to measure participants' posture and falls during a simulation of falling downstairs. So the findings indicated people living with Alzheimer's and a history of falls had significantly worse postural stability, a significantly longer lag in cognitive for postural correction, and significantly delayed reactions to falling, compared to both those who had Alzheimer's but no history of falls and those who were cognitively intact. But this is one very small study, and although the review authors suggest it could be used to assess falls risks and develop VR interventions to improve balance in the future, we rated the overall quality as low on AMSTAR because it was such a small study and the results were not conclusive. Interestingly, we actually found no reviews of apps specifically focusing on dementia and falls, which was quite surprising. But I think as the talks yesterday by Emma and Millie and Helen showed, this is an area where we're doing a lot of development and there's a lot of research going on. So I think in the future, we would expect to find evidence in these areas. Next slide, please. So as I say, our review of reviews found limited evidence, with most of the reviews we included being based on small studies with weak methodology and short follow-up periods. This means the evidence is not robust and we don't know if the technologies had any longer-term impact on falls. We judged the quality of most of the reviews we included to be low or critically low, often because they didn't consider the quality of the studies they included when drawing their conclusions. A lot of the evidence was indirect, which means that the studies included in the reviews didn't directly measure falls, but instead measured other outcomes such as balance and posture. And whilst those can help predict falls risk or develop new technologies to reduce falls risk, they don't actually tell us about the direct impact on falls. So we suggest that more robust methodology is needed for real-world applicability, with clear and validated measures to record the type and level of participants' cognitive impairment, better designed studies, and more standardized fall outcome measures. Also, although we know that people living with cognitive impairment could benefit from these technologies, they're often actually excluded from the development and testing phases. There's some evidence to show that people living with dementia can find technology and the use of technology unsettling, and they may actually become distressed or refuse to use it. So it's really important to consider as wide a range of users when developing the technologies to make sure they're usable and acceptable to the group who's going to use them. None of the reviews we included reported on whether users, staff or carers had been involved in developing the technologies, nor any on consideration of the wider context when implementing such technologies. So, although digital technologies may have the potential to reduce falls and falls risks for older people living with dementia and cognitive impairment, which could in turn help them to live longer in their own home, the effectiveness of the technologies is really yet to be established, and we found insufficient good quality evidence at this stage to recommend which technology is best placed to do this. But obviously, it's an ever-evolving area, and the opportunities to develop technology alongside people with cognitive impairments continues to grow. So I'm going to end there, but I'm happy to answer any questions now, or if you want to put them in the chat, and I'm happy to answer them later as well. Thank you very much.
Brilliant, thanks Charlotte. That was great. We have got time, so I'm just going to open it up if anyone's got any questions or comments or thoughts on Charlotte's presentation, or if not, you can pop them in the chat, and I'm sure Charlotte would kindly answer those as we move on. Any questions? No? Okay, we'll move on. I'm sure some might come to people as we go. Okay, I'm just going to reshare my slides with you. Just one moment. So I'm now going to hand over to our next speaker, which is Elaine Stott from Rochdale Your Trust, who's going to talk us through some work taking place in Rochdale around falls prevention collaboration. Thanks, Elaine.
Okay, thanks very much, Beth. I don't have any slides. We are a very new collaboration, and we're still kind of in the process of working out what the collaboration will be moving forward. So I'll give you an overview, but if anyone is interested, obviously I can send further information as we run everything through. So yeah, my name's Elaine. I work for Your Trust in Rochdale. I'm the active living lead. So I focus on older adults and people with long-term health conditions throughout our programmes, of which we have many. And the falls prevention collaboration started originally as just after COVID, when we realised that residential homes, care homes, sheltered housing, etc., had been so alienated during the COVID pandemic. People had become so deconditioned, and that we really needed to look at what our offer was moving forward for them in the future, and how we could engage with them if a pandemic ever happened again, or if anything like that ever happened again. So we started very, very small. We made a video library of 12 exercise videos based on the Life to Life Falls Prevention Programme and the Otago Programme. Put the video library together, emailed out to residential homes and sheltered housing, etc. within our area, and asked who would be interested in being a pilot for us and having a little test through. We offered 3 different types of help. They could either just access the videos on their own, play them in the lounge, and people could go through the exercises. They could access the videos and access a member of our team to go in and discuss with staff sort of how we went about the exercise programme and what we were going to do. Or they could access a member of our team and the video library, and then also engage in our external services within the community and get people to come out and see us. So that was a starting point, and that's where we started from. And then we sent that out, and then other people started to get involved, and this is when the collaboration really started to happen. So the first person who got involved was actually from Greater Manchester Moving, and Claire Marshall from the Active Ageing Workforce Lead. And she got in touch because she realised that we have a massive issue here with the workforce not being as active, especially within these areas. And if we could get the workforce more active, they could encourage the participants to be more active, and it was a win-win situation for everybody. So she got involved, having the chats with them on how we could work with workforce, how we could train them up. We then managed to get involved adult services and their care marketing training coordinator, who came forward very excited again about how we can train the workforce, how we could train volunteers, how we could train the adult care OTs, the social care star services, the community champions, to again be encouraging people to be more active and get that knowledge out there. After that, we kind of moved on, and the Carers Hub got involved as well. So we got the Carers Hub, we got volunteers, hospital volunteers, all on board who want to do some training, want to be more active, want to help prevent falls with the people they're working with, want more information. After that, the big one for us is we got a phone call from our falls team with the NHS, especially from the falls and frailty team who work within the residential homes and care homes. Our falls lead, our FEMA lead, all got in contact with us to ask how we could then work with them on getting things in place so we can ensure that we can help to prevent these falls happening with the people they work with, as well as our bigger range of preventative measures. So that was kind of who we now have on board at this moment. There's a couple of other people who are coming on board with us, and I'll go into that. We had a little chat about what our offer was and how we integrated the offer a little bit bigger into everybody else's work streams as well. What we're just in the process of putting together now is how that offer will look moving forward. Some questions came back regarding the video library, although the video library is very good. Everyone likes what we've done. Obviously, different teams see things differently. The agreement has now been made that working with the frailty and fall teams from the NHS and FEMA lead, that we will make another series of videos. These will be some smaller, just one exercise videos that they can pick and choose for each of their clients. So they will see a client within a nursing home, a residential home or care home. They will then, at the end of their series of time with them, say 12 weeks, they'll be able to pull out a series of exercises from our video library and let that person know these are the exercises that they want them to carry on with. We will then look at putting a volunteer or a member of staff or a member of workforce in place within that residential and care home as well, who will help work with that person on those exercises so they become integrated into their everyday life, therefore keeping them more active, keeping them moving more, helping them obviously to prevent any further falls or any further damage. That's one section that we're moving down. That way is going to work as well with adult care OTs. They are looking at referring people into our services for our community classes, as well as utilising the video library moving forward. So they will work in the same way. We then also realised that we need to do some more education around the prevention of falls and preventing the first fall from happening. So although we have lots of work going on when someone has fallen and getting hold of them after that, how do we prevent the first fall? We actually ran our very first pilot yesterday as part of Falls Prevention Week, where we combined functional falls assessments with the ROSPA Fall Fighter training and the Moving Medicine Get Up and Go booklet as a knowledge and education session. We had, without really any advertising, 35 people attend that session yesterday. 35 people are now trained ROSPA Fall Fighters. 7 of them have signed up to our volunteer programme to deliver that in the future for us out at other places. 35 people had functional fall assessments, and we have signposted people into our falls prevention classes, into our strength and balance classes, or into our general gentle exercise, water walking, aquatics pathways that we have for people to keep them moving more. So this is running again on Thursday and running again on Friday in slightly different ways across the week, so we can work out what way works better. As we put that out, we've already had HMR Circle get in contact with us. They would like us to run the training out across themselves as well. They're actually now coming into partnership with us as well. HMR Circle in Rochdale specifically hold our digital offer. They can do digital training for people. They can hire out iPads. They can hire out technology. They can work with people on Wi-Fi connections. So the ability to access the video library, access the ROSPA training online, and access all the other information we have on our web pages would be a massive part of Circle's remit for us moving forward. Together with that, we have just planned masterclasses to be held for the workforce, where we will be going through the ROSPA training, strength and balance exercise training, basic coaching points for somebody, backwards training, how to get somebody off the floor, how to talk them through, We also have a nutrition and hydration team in service with us. They will be doing an education session on hydration nutrition for people to prevent falls. And we're integrating that into a masterclass for workforce as well as into community classes. Across the borough, we've already been spoken to by 4 community centres to run these training courses across the borough. So what kind of started as a very small, let's just put some videos out so we can get some people in care homes moving a little bit more, has become what we've classed as quite a huge prevention programme and collaboration across all the major services within Rochdale. Everyone has their part to play. Everyone is collaborating together, and that's why we've called it a collaboration. Everyone has got this certain part that they're doing, but everyone's working so closely in line with everybody else that moving forward, we hope to start rolling out in January. We've got a couple more pilots to do before the end of the year, that this potentially hopefully will be best practice in this area as we move forward. I think that's about it.
Brilliant. Thanks so much, Elaine. That sounds incredibly exciting, and great. Can't wait to see, you know, start to look at some of the impact of that work. Just to say, I think there is a question in the chat.
Yeah, just saw it. So Rochdale, yeah, Rochdale Borough. We consist of Rochdale, Middleton, Hayward, and Pennines. So that's the areas that we cover. If everyone knows where those areas are, but it will be across all 4 of those boroughs within the Rochdale area.
Perfect. Just to say as well, we are launching on Thursday our first community of learning, sharing and problem solving. And one of the ideas around that is that each local area can come and bring, you know, and share what's happening within each of the boroughs. So it'd be great to continue to, if you want to be a part of that network, to continue to share the progress as we go, because I know a lot of other areas would be really keen on that approach as well. So that sounds fabulous. Are there any other thoughts, comments or questions before we move on to our final speaker?
Can I just say, I work in, sorry,
No,
I work
it's fine.
in Radcliffe Primary Care Centre, so we cover Bury. I'm one of the physios. We have a lot of fallers. So we kind of see patients between ourselves and the community falls team. But there's so much pressure on the waiting list, as you can imagine, because I think there's only 1 or 2 physios on that team, and something like this would be great in Bury, but I don't think they cover. There's talks of that in our borough at the moment, is there?
So I know Shelley Caulfield, who heads up the Bury team. She is very, very good. Bizarrely, one of my staff who works on my team also works on the Bury team, which is quite handy. I know we do work very closely across the 10 areas of GM in contact with that. And I know we work very close with Bury because we are literally next door. And obviously, hospital, if people are in Fairfield, sometimes they come into us from Hayward or Rochdale, or sometimes they're out into Bury. I know Shelley at Bury's looking at what we're doing. We are in contact with her, so hopefully if we can prove how much this is beneficial in sort of the next 6 months, it could be something that we definitely could look at rolling out across the other boroughs.
Thank you.
No worries.
Brilliant, thank you. And yeah, and just to say, you know, the whole reason for the Greater Manchester Falls Collaborative is to highlight examples of best practice and what we know is working, to make sure that we can look at rolling initiatives and approaches out across Greater Manchester. So that's great. Thanks again, Elaine. Brilliant. So I'm just going to introduce our final speaker. So we've got Kimberly Green with us today from the University of Manchester, who's going to take us through. We've managed to go back to the beginning. Just bear with me 1 second. Is going to take us through our final presentation on the effectiveness of dance interventions on falls prevention in older adults. Thanks, Kimberly.
Thank you, Beth. So good afternoon, everyone. Thank you for having me today. My name is Kimberly Lazo-Green, and I work with the NIHR Policy Research Unit, Older People and for Older People in Frailty, based in the University of Manchester. And part of the work that we do in the PRU is producing evidence for policymakers and help the DHSC make informed decisions about the needs for older people. So earlier this year, we have received a request from the DHSC to examine whether dance-based interventions are effective in preventing falls in older adults. And I am here today on behalf of my colleagues to present our findings from a rapid review that we conducted earlier this year, where we explored the evidence that existed around the effectiveness and cost effectiveness of dance interventions for falls prevention among older adults. Next, please. So it is argued that, generally dance is an enjoyable and sociable form of exercise. And there are many reasons why we dance, regardless of age or culture. And we know that dance can provide a lot of entertainment, relaxation, and even social interaction, especially when it is enjoyed with a dance partner or collectively as a group. Now, based on this, there are chances that dance interventions have higher uptake and adherence when compared to more formal exercises. And also because of this, dance was deemed as an alternative approach to falls prevention. Now, in our review, we referred to dance as a 3D exercise. Sorry about thinking, click next, please. There's a little bubble there that should pop up. There we go. In our review, we referred to dance as a 3D exercise, which is defined as a constant movement in controlled, fluid, repetitive way. And this was from the profane false taxonomy, where examples of 3D exercises included dance, Tai Chi, and Qigong. So what do we know about dance intervention and falls prevention? Now, there is some evidence to suggest that dance has physical and mental health benefits for older adults, but we also found that these dance programs normally do not focus on the types of exercises that are known to prevent falls, such as balance and functional strength exercises. Now, we know that there is also strong evidence that balance and strength exercise programs are effective at reducing falls, but there is still insufficient evidence to say that dance interventions do the same. While literature suggests that dance may improve falls risk-related factors for older adults, this does not directly mean that dance can prevent reducing the incidence of falls. In fact, in a recent Cochrane review investigating exercise interventions for falls prevention, there is only one evidence that Tai Chi, a form of a 3D exercise that can prevent falls, but other forms such as Qigong and dance have low certainty on their effectiveness to prevent falls. There is also a lack of strong evidence to suggest that cost effectiveness of dance interventions. So single factor interventions that are balance and strength based, such as Otago and FAME, there's some evidence that they are cost effective, but more robust economic evaluations on the effectiveness of dance based interventions still need to be widely examined. Next, please. So in order to address these issues, we conducted a rapid systematic review and meta-analysis of the literature on dance intervention and falls prevention. And we focused on both experimental and non-experimental studies that looked at dance interventions for adults aged 50 and over. And we focused on the primary outcomes of falls, risk of falls, and concern about falling. And our secondary outcomes were the proxy markers for falls risk, such as functional measures on balance and strength and quality of life, in addition to cost effectiveness. Now, we assessed the risk of bias of these studies using the Cochrane's risk of bias tools for both randomized and non-randomized studies. And we used the grading of recommendation, assessment, development, and evaluations approach, or GRADE for short, in order to assess the overall quality of the evidence. Now, this enabled us to rate the quality of the evidence from a group of similar outcomes, and it can be rated as high, moderate, low, and very low, where quality can be downgraded based on inconsistency, imprecision, indirectness, or publication bias. And when possible, we performed a meta-analysis on randomized studies with sufficient post-intervention data, and the rest were synthesized narratively. Next, please. So our initial searches identified 397 studies, and after removing duplicates and screening for title, abstract, and full text, we included 41 studies in total, 20 of which were randomized studies and 21 were non-randomized. There were different types of dance found in these studies. So some were social dances, primarily like ballroom and Latin. There were dance-based exercises. So these are dance-based exercises that focuses on cardiovascular exercises combined with multiple dance styles. Then we also have cultural dances. These are primarily traditional folk dances associated with a particular population and culture. There were also dance-based therapies, which focused on movement psychotherapy. And finally, we had low-impact dances, which were contemporary dances with low-impact movements. As with previous systematic reviews that were done before, majority of the papers focused on proxy outcomes, with at least 38 of these studies reporting functional measures on strength and balance, but only a small minority of these papers actually did report falls outcomes. Next, please. Now, in terms of the key findings on the effectiveness of dance interventions, overall, we have found that there is very low certainty on the evidence across all key outcomes. And what this means is that we are uncertain about the effect of dance interventions in improving falls due to various reasons. So for the primary outcome of number of falls, as mentioned earlier, only a small minority of the studies have reported falls outcomes, and there were only 6 to be exact, and only one of these studies actually reported post-intervention falls data. And this is a randomized study that looked at the effectiveness of Argentine tango. And while it shows there was a reduced risk of falls for older adults when compared to usual care, there were still some concerns on the risk of bias and imprecision of this study due to the small number of participants. And similarly, for studies that assessed risk of falls and concern about falling, there was inconsistency on the direction of the effect, and there various measures were used. So the overall grade on this evidence is also very low, which means that we are uncertain on the effect of dance interventions on decreasing the number of falls, risk of falls, or concern about falling. Now, for the proxy measures, we looked at outcomes on falls-related risk factors, such as functional measures on strength and quality of life, and there were also varied measures that were used across the studies. Now, this made it more difficult to conduct meta-analyses due to heterogeneity. However, we were only able to do that for 4 functional measures, and these were the timed up go, sit to stand, 6-minute walk test, and Berg balance scale. Our findings have shown that there is no significant differences between dance and control groups, and the overall rating on the evidence was also very low, where most evidence was downgraded for risk of bias, inconsistent estimates of effects across all studies, and imprecision as well. So we are uncertain about the effect of dance interventions in improving functional outcomes, strength, and quality of life. Now, finally, we only found one study that examined the cost effectiveness of dance interventions, and this was a UK-based dance intervention called Dance to Health. The authors have claimed cost savings, but we must be very cautious in interpreting the results of this because the study has critical risk of bias. So the authors have reported from a subset of the sample, and the economic methods were not well justified. So at best, it should be considered exploratory, and a more robust randomized controlled trial is needed to confirm the claims of this evaluation. Next, please. So to conclude, in line with the World Guidelines for Falls Prevention and Management, our findings have shown that there is very low certainty on whether dance can prevent falls. There was considerable heterogeneity found across all studies, including the variety on the types of dances and conditions across population groups, and certainty on the evidence is very low due to imprecision, inconsistency, and high risk of bias across the studies. What this means is that we know that dance may provide benefits to older people who take part. However, there is still insufficient evidence to recommend dance as an alternative to strength and balance training if the aim is to prevent falls. There was also no current robust evidence found on the cost effectiveness of dance interventions for the prevention of falls. However, this does not mean that dance is not beneficial at all. If we are to, follow the World Guidelines for Falls Prevention Management recommendations, it may be that older people who are at low risk of falls could potentially benefit from participating in dance if it is part of a structured progressive program delivered by trained professionals. Further research is still warranted in this area, especially in terms of randomized studies on dance being put head-to-head with falls prevention interventions that are known to be effective, such as Otago and FAME. Next slide, please. I think that's the last bit. Yeah, there we go. Thank you. If you have any questions, obviously we have time, so try to address them as much as possible. If you have questions, pop it in the chat. Thank you.
Brilliant. Thanks, Kimberly. That was great. yeah, we've got plenty of time for questions. So if you do have any, please do raise your hand, and we'll bring you in. No. Oh, do you want to come in, Chris?
It feels unfair to ask members of the team. Yeah, very good review. So the bottom line here is that we can't recommend dance be purchased as an approach if we're going to prevent falls, but it might be good for a cardiovascular health and things like that. Makes people feel good. That's okay. Yes. And I guess you're going to publish this soon.
Yes, hopefully.
It really is. I know the dance question is a burning question because it came from the department nationally. I mean, they really wanted to understand whether things like Dance for Health actually do what they say, and I think we have to be very careful and make sure that you know, if you are looking to consider dance as an intervention, to make really clear that you know what you're doing with the sorts of dance, the different sorts of dance interventions.
And I think this is really useful for making sure we educate commissioners on what we know about the research. So we, you know, people who are commissioning falls prevention are actually commissioning evidence-based interventions that we know is going to have that desired effect of reducing falls. Definitely. I think we do have a question in the chat from Laura. Does there need to be clarification around what needs to be measured for falls prevention?
Definitely. I think Chris would have more knowledge on this, but just probably to address it, you know, in our review, we found there was only 6 studies that actually addressed, you know, measuring the number of falls when performing in the dance or participating in the dance, and the others were proxy markers. And I think it was very similar as well with the findings that were, you know, that Charlotte and then her team has done as well.
I'll pop in and say yes. Back in, I can't remember, 2005, 8, can't remember the date. We published as Profane, the Prevention of Falls Network Europe, published some recommendations for core outcomes for any studies looking at the prevention of falls. So counting the number of, and of course the ways of doing it. So it's counting the number of falls that occurred, account over what time period, and then how one presented those data, to be really clear. So there is a key recommendation about outcomes. And I think the world guidelines are also quite clear about what should be measured. But we might come to that on Friday.
Yes, we do have a session on the World Falls Guidelines by Chris on Friday. So if you're interested in that, please do come along if you've not signed up already. Any other thoughts, comments, or questions at all, or any of the presentations from today before we wrap up? No. Okay, well, thanks ever so much to our speakers, brilliant presentations, and thanks to everyone who's been able to join us today. We did have over sort of 90 people register, so I appreciate not everyone's been able to attend in person, but as I say, the session has been recorded and the slides will be available. Just to say as well, if you've not already received the social media toolkit that we've pulled together with NHSGM and GMCA, please do drop me an email. In fact, I will just reshare the slides so that you've got my email address. Yeah, my email's on the screen there. Please do drop me an email and I will send that so you can utilise that across your organisation. And if you are attending any other sessions in the week, we look forward to seeing you again. And if not, thanks ever so much for your attendance today. And we will be sending out everything by the end of the week. Thanks ever so much, everyone.